gentlemen, with a small delay, but we are moving to the, I hope, most hot final topic of this session, so adenomyosis. No doubt that adenomyosis is actual, regardless the kingdom you belong to, and I'm sure that the association between adenomyosis and infertility exists. So, but we still have a lot of questions. So my pleasure, my big honor is to invite for this stage, for the speech, the professor of Open Gene of Harvard Medical School, the past president of AGL, the honorary member of ESGER. So, Isaacson, this is your stage.
Thank you very much. Okay. Thank you very much for the invitation. This is one of the most fun talks I was able to put together, because when Attilio asked me about a year ago and he assigned me this session, I said, Attilio, you didn't assign me a topic. He said, just say whatever you want and just give us an indication of what future research is needed in adenomyosis, and that's what I'm going to attempt to do. So the title is Adenomyosis and Endometriosis. It's time to separate the A from the E. Why do we need to separate adenomyosis from endometriosis when we think about this disease? Well, what do we know about adenomyosis? The only thing we know is we're pretty consistent when it comes to the symptoms. These patients usually present with heavy menstrual bleeding, painful menses. I thought they had embryo implantation disorders until yesterday, so I put a question mark there. And then on histology, all we know is that there's the presence of epithelial glands and stroma in the muscle of the uterus. That's all we know. Here's a partial list of what we don't know about adenomyosis. We don't know the incidence or the prevalence. We don't know how often it's in adolescents or in patients who are early or in late reproductive age. Most of the symptoms that people attribute to endometriosis, 80% of the symptoms include dysmenorrhea, dyspareunia, are probably due to adenomyosis and not due to endometriosis. We don't understand the etiology of adenomyosis. We have no consensus on the histologic diagnosis. We have no consensus, I would say, on the imaging diagnosis of adenomyosis, and we'll hear about that more in this session. We don't know what it is about the presence of glands and stroma in the myometrium causes all these symptoms in patients. We don't know the proper treatment, and we certainly don't know how to prevent it. So Attilio, that's my short list of the research that's necessary. But what happens when we don't know something is that we tend to talk like we do know. So there's a wonderful saying is that what we don't understand is not a problem. What we know that's not true is the actual problem. And so we have myths that come along with adenomyosis that's persistent from generation to generation. One myth is that adenomyosis is more prevalent in women of the late reproductive age, and adenomyosis is more common in women who've had children and who've had prior uterine surgery. Why is it more common in that population? Because those are the women who are at the highest risk for hysterectomy, and hysterectomy was used to make the diagnosis. Myth number two, that adenomyosis can be diagnosed by ultrasound or MRI without even having a biopsy in young reproductive age women. So what my point is that when you see these changes in the uterus by MRI, by ultrasound, and you don't have a biopsy, then you see changes that are consistent with adenomyosis, but I'm not sure we're seeing the real adenomyosis because we don't have a biopsy to prove it, and we don't know that the disease is the same in a 20-year-old as it is in a 49-year-old. We don't have that longitudinal data. And myth number three is that adenomyosis is the same as endometriosis, but it's just in the uterine muscle. Well, this is what we're going to focus on mostly. Cells in different environments behave differently. The behavior of larger aggregates of cells emerge from the interacting behavior of the constituent cells, their non-cellular components, such as the extracellular matrix, external boundary conditions, such as the nutrient resources. This has been known for a long time. So you take an epithelial cell, a gland from the endometrium, and you put it in the muscle, it behaves very differently than if it's on the serosa of the peritoneum. So I say to you, is endometriosis, where you see the cystic and glandular appearance, the same as adenomyosis, where it's deep in the muscle of the uterus? And my argument's going to be it's very different. It's not the same disease. They're not comparing apples and apples. So we want to get clarity on this. And what the Griffith Lab at MIT that I've been pleasure to be a part of has been focusing on is, so let's try to define the microenvironment of adenomyosis. So first thing that was done by Juan Necco is that he took, you could see a sample of uterine tissue all the way from the endometrium to the serosa, and if you clear out all the lipids, you can have that same tissue look like this. If you do a 2D histology on this sample, you'll see what looks familiar for adenomyosis. But if you actually do the light sheet imaging, we can see that these glands, which look very benign, are actually forming an entire network going all the way through from the endometrium all the way to the serosa. And that really opened my eyes to say, wow, that's very different from what I thought adenomyosis was all about. We really don't understand it. And so we really want to look at what are the factors that influence the behavior of the epithelial glands and stroma in patients with adenomyosis. So there are systemic factors such as cytokines and hormones that are very different in the muscle of the uterus than they are in the peritoneum. You look at the host tissue, the surrounding smooth muscle, the fat, the connective tissue. And you look at the hormonal cues that these are these signals that drive the behavior of the cells. Look at the biochemical host environment is very different in the muscle of the uterus than it is in the peritoneum. They're two different diseases. So we wanted to, again, let's take a look at what we can now see as something we're familiar with. So here on ultrasound, we can see an adenomyotic cyst. And then again, if you look at the gross pathology, this is what the cyst looks like. Look on 2D histology, this is what the cyst looks like. And now let's take a look at what it looks like when you look at a 3D histology and all the architectural and the microenvironment. So what we focused on is just try to stain for the myometrium, the muscle, let's stain for the vasculature, and let's stain for the nerves and see what we can learn about adenomyosis. So here, if we just look at the vasculature, and this reminded me of Rudy Campo's talk from yesterday where he saw the neovascularization of these lesions around adenomyotic tissue. You can actually see this in 3 dimensions. This is very real. If we look at the nerve fibers in lesions with adenomyosis, we can see that there's actually an increase in the nerve fibers surrounding these glandular lesions. Now it starts to make sense why these patients might have some type of dysregulation of the contractions of the muscle, and it makes sense that these patients have more pain. There are more nerve fibers there. Look at the vascularization of these lesions. And we can be able to demonstrate and to quantitate the amount of vascularity around the lesions compared to normal myometrium, and we see that there are more blood vessels around these lesions, which might help explain why there's heavy menstrual bleeding in these patients. And then we look at the nerve fiber spatial segmentation. And what you can see here in a 3-dimensional, and again, these are not cartoons, these are actual 3D histologies of real lesions. And you can see the nerves that actually invade these lesions. and surround the glandular epithelium, as you see is represented in purple. And again, this, if you just put the whole thing together, almost like a 3D puzzle, you see the glandular epithelial cells. This is to try to define the microenvironment that we're looking at in patients with adenomyosis, surrounded by the vasculature, and then the muscle, and then the nerve fibers. And you can start to make sense why these patients have problems with various problems, such as heavy menstrual bleeding, pain, and possibly implantation failure. And we know now that adenomyosis is not just one disease. We see various types of adenomyosis in 3D lesions. We see cystic lesions, we see glandular lesions, we see diffuse lesions, we see invasive ends to these lesions. And this, again, might help explain why people will say, you know, 50% of my patients who have adenomyosis have no trouble getting pregnant. Well, adenomyosis is not adenomyosis in every single patient. There are different types of adenomyosis that we just don't understand yet, but we're beginning to define the environment. And this is one of my favorite slides because finally we can see this is the smooth muscle hyperplasia that surrounds the lesions. And it shows, it makes sense why you would have some disruption in the normal peristalsis that's needed in patients for implantation on the inner myometrium. And this was shown beautifully by Connie Reese and Dick Shute, who looked at the peristalsis of the junctional zone in patients with and without adenomyosis. And just in summary, they showed that there is certainly disruption in the normal junctional zone peristalsis in patients who have the adenomyosis. And again, it starts to make sense why these patients might have implantation disorders. Now, that's 3D histology, and we've kind of taken it now to another level where we're looking at really autofluorescence using label-free imaging of this same tissue to see what else we can learn about it. And this is just the picture of a label-free inverted microscope, a laser photon microscope. I'm sure every IVF lab would like to have one of these. But these are the images that we can get from this type of technology. So on your left, you see the H&E staining of the endometrium. Look at the label-free autofluorescence nonlinear microscopy that shows you stromal cells, lymphocytes, epithelial cells, immune cells, and erythrocytes. And you can see, as you go through it in a 3-dimension, we can actually see immune cell infiltration of the epithelial glands. Okay. And then the most fun part of our laboratory sessions is when we have these surprises, when we see these purple linings of an endometrial gland and we have no clue what it is, and we get together and we try to figure it out. And again, this is the applications. We've used this on adenomyosis tissue. And then you can actually do this on live tissue. So you can actually see what is happening with adenomyotic tissue in live tissue in real time. Now, next step is these organoid, let's see if I can get this to work. If we take a endometrial gland and we make an organoid out of it and we put it in a soft matrix, which is like the serosa of the peritoneum or the endometrium of the uterus, we see that these organoids are very, very happy and they just kind of stay right in place. Now, you take that same organoid and you put it in a stiff matrix that resembles endometrium, and what you see here is you'll see that there's actual invasion of and migration of the endometrial cells into what is similar to a muscle. Now, why is this important? Because we tell ourselves that we think we know what causes adenomyosis. We think it's from the disruption of the basement membrane in patients that have had pregnancies or uterine surgery. This organoid model has no disruption of the endometrium. This is the behavior of the cells in an abnormal environment. So again, the reason I bring all this up is because we should be rethinking everything we thought we knew about adenomyosis. And again, I'll skip through that. But this is where I want to end up. So where we are with adenomyosis now is where we were with endometriosis 50 years ago. So I want to read you something that was written by V.Z. Buttram in 1979 about patients with endometriosis. And it says, typically our patients with endometriosis appear to have an intense desire to excel. They are tense perfectionists and demanding in specific goals. They are usually well-dressed, they have trim figures, most are employed as secretarial positions or in professions such as law, medicine, or teaching. And once they are aware of an infertility problem, many of the patients will have an obsessive desire to conceive, and they all seek possible avenues of assistance in an expeditious route. Okay, this is from 1974. We know that's not true. But this is where we are now with adenomyosis, okay? We've used bad data to get us the understandings that are actually false. So our bad data is we can't rely on hysterectomy data, number one, because adenomyosis likely starts in adolescence. 15% of women or kids who go to high school miss at least 1 or 2 days from school because of painful periods. That's not normal. It's likely due to adenomyosis, and we just haven't been able to diagnose it. And endometriosis has really advanced because there are literally tens, if not hundreds, of endometriosis associations. How many adenomyosis associations are there? Close your eyes and what do you see? There are none. And I would say to you that adenomyosis is more prevalent, it's probably more important, and it's more impactful on our patients of reproductive age than endometriosis, and we need adenomyosis associations in research that are separate from endometriosis if we're going to have progress. So we need to separate the A from the E to make progress. This is not the first time in the history of medicine that we've had to separate the A from the E, where you had to learn the difference, in medical school, but the difference between an ass and an elbow, which was an A to E, and we need to learn the difference between adenomyosis and endometriosis. And I have one last comment. I think there should be a fourth kingdom. All of you who agree, please, please clap your hands. The fourth kingdom should be the myometrium. All right. I'll just be wearing this like that. Thank you very much.